Good afternoon and welcome to the second breakout on citizen empowerment and personalization. We feel that this is a very important topic, which the NHS has long had as an aspiration to put patients at the center of care. We took the exercise of looking at successive waves of reform and picking out the emphasis on patients in previous times. So, for example, from the NHS plan in 2000, which launched the expert patient program, through to the Wanderlust report calling for a more patient-centered service, commissioning a patient-led NHS, Our Health, Our Care, Our Say, etc., through to the current wave of reforms, which have stated the aspiration from Andrew Lansley, no decision about me without me, through to putting patients first, and right now, everyone counts. So clearly, this is an aspiration. However, if you talk to a lot of patients and service users, they will tell you that there is a little bit of a disconnect between this aspiration and what really happens in day-to-day service delivery and in commissioning. And so the question really is, how do we bridge this disconnect? What are these patient needs that are not currently being met? What does it mean to actually deliver against these needs in practice? What does citizen empowerment mean in practice? Are there things that we're doing particularly well at the moment that we can build on? And I would really encourage you in the audience to share, if there are specific examples of good practice that you would want to share with your colleagues. Times are tough. What should we really focus on in terms of getting a maximum bang for our buck? And really, just how big a priority is this? I was just joking with one other member of the audience as he was heading off to another breakout, and I said, well, this is the one on citizen empowerment. He goes, yuck, who cares about that anyway? He was joking, but is there a little bit of a sense that we always have to pay lip service to this, and once we've actually stated that it's about patients and tick that box, we can move on to the real problems of the NHS, which is about balancing budgets, etc. And whose problem is this? Is there a real risk that once that box has been checked, it becomes somebody else's problem, and then patients then fall in between the cracks? So we've got three very interesting speakers to talk about different aspects of this problem. So first of all, Helen Davis, who is a patient herself and a cancer sufferer and survivor, as well as a patient carer with family members who have also suffered from cancer, who has since become a very active patient advocate and will give the point of view of what it feels like to be a recipient of services. Jeremy Taylor, who's the chief executive of National Voices, is a coalition of charities that speaks for patients, carers and communities in various fora. And Jay Stickland, who's the Senior Assistant Director of Care Management at Greenwich Council, a former nurse and social worker, who will give an example of how parts of the system have been trying to respond to some of these challenges. So without further ado, we're going to jump straight in with Helen giving us her story.
Thank you for the chance to talk to you. I'm Helen. Although my experience is primarily around cancer, just to say that I think a lot of it is as relevant to other long-term conditions as cancer. I was diagnosed with breast cancer, a very common cancer, 10 years ago, and then 3 years ago had melanoma in my eye, which is unrelated and rare. So I've been treated at 5 London hospitals. I've also been a carer for various family members in London and out of London. I also chair a Pan-London patient group at St George's Hospital. So when I was thinking about what to talk about, it did kind of cluster around 2 groups of issues. One around personalisation, around me and us as patients, and one around care across different sites and services. So I'll just talk about those 2 themes. So at the time I was diagnosed, I was a patient, but I was also the main breadwinner, my husband having recently been made redundant. I was a would-be mother. I was a manager, friend, colleague, whatever. So being a patient was part of my life. Cancer directly impacted on all of these things. Most notably, the option of being a mom was no longer an option. And I was never offered help with any of those aspects of the impact of the cancer itself or the long-term consequences. I had very aggressive treatment, for which I'm immensely grateful because I'm still alive. But the consequences of those treatment are significant, and I was not offered help with any of that. So it's just a kind of plea, really, to be thinking more widely. And some of the things that I think work, the holistic needs assessment that Macmillan's been a big advocate of, or the concerns thermometer, it's called at St George's, I don't know what it's called elsewhere, a really simple, easy tool, which is like a thermometer. and it enables staff, it doesn't have to be a clinician, to say to someone, if you want help, advice with things like finances, your relationships, work-related issues, etc., let us know and we will signpost it. So it's not a big laborious needs assessment, but it gives people permission to say, actually, this long-term illness is really impacting on my life and I'm struggling. I was very fortunate to be able to go back after, well, I worked part-time through 9 months of treatment and then returned to work. I was at City Hall at that stage, working on health issues. But work was hugely important to my recovery. It was physically exhausting, but mentally an absolute lifeline. But I had to make all that provision myself, really, and make it work for myself. And there's this big sort of think positive approach amongst many staff, well-intentioned, I'm sure, and family members. But it's just really to allow us to ask for help, and really this point about, asking for help is not admitting defeat. Long-term conditions are hard to live with. Treatment gratefully received, but it has an impact on many aspects of our lives. I never received social care in either of my cancer journeys or my role as a carer. But a lot of what I was struggling with, probably whether social care or third sector or other providers, there are people out there who I should have been advised to get help from. So really, pick up the easy tools, I think, and do something about that. And then the second theme around integration or lack of. What does a lack of or a disintegrated service look like from a patient perspective? As I say, I've been treated at 5 different hospitals, under 3 at one time, and the reality of falling between the cracks and no one taking responsibility was absolutely terrifying, from the point of a receptionist literally saying, I need these tests because the surgeon won't do the surgery for the melanoma without this staging information. And she literally looked up and said, what do you want me to do about it? And it's devastating when you're a patient and you've got a melanoma, which is, could be serious. And then at the end of that same journey, in a hospital bed, my eye was fine, they said. Well, it was fine at that stage. So the eye team signed me off. The duty physician said I wasn't their problem, even though I'd had a really bad response to the anesthesia. And it's really terrifying as a patient. But it's also the day-to-day stuff of having to remind people every time I go for a blood test not to take it from my left arm because of the lymphedema risk, etc. So it's from little things like that to the bigger picture. So really, again, what do I think works? And this is my last slide. I've been really fortunate. I've had the same clinical nurse specialist for 10 years. I've got the same GP for 22 years. So whether it's a CNS, an admiral nurse, a care navigator, a key worker, someone who knows the system and can help us navigate it is critical. And I really think there's sort of no wrong door principle. Somehow, wherever we as patients tip up, you're not going to be told, not my problem. Somehow, embedding that in the culture of our services would make a massive difference. And I do think that we don't invest enough in supporting and valuing non-clinical, non-professional frontline staff, the receptionist who gets all the flack from distressed patients and clinicians whose lists are over full, etc. And really investing in those non-medical, non-professional, but critical staff. And really, which I know others will talk about, valuing and recognising the huge impact on the people who love us as patients and service users, and their role and their need for being involved in the whole process. And just to say, back to the first picture, I'm a part-time patient and survivor. I am also thankful. I was laid off while on a phased return from my second cancer treatment, but I am working again. I am a colleague, I am a friend, I am still a wife, thank God. My husband stuck by me, they don't always. But we and you are not that different. I hear so much the language of them and they and patients, and we're all patients sometimes, we're all service users sometimes. And my experience at St George's is that the patients and clinicians are much more often than not pushing in the same direction in terms of service improvements. We're not, we can be allies to you in trying to improve services, not a source of challenge or constructive challenge, but we're pushing in the same direction often.
Hello, my name is Jeremy, as people say in the NHS these days. I'm going to talk about actually the same things that Helen was talking about, but in a slightly different way. And I think it's very interesting, the introduction that we have from Sundiatu about the history of progressive waves of reform trying to put patients at the heart. And I think it's still to play for, actually. I think the central role of the patient, in a way that doesn't feel like some hippie fad, but is actually mainstream to how you deliver good healthcare, I think is still to play for. Just by way of an illustration, this administration came into office in 2010 with a health manifesto that was essentially no decision about me without me. That was Andrew Lansley's strapline. We've gone over the last 3-4 years from no decision about me without me to putting patients first. And I just invite you to reflect on the difference between those two statements and whose point of view they're from. So I think we haven't overcome the forces of paternalism by a long way, but we need to. National Voices is a national coalition. We've been going for 5 years. We do a lot of work around trying to articulate and champion the patient voice, the voice of the voluntary sector in health and social care, really important. How to improve the deal for people with long-term conditions and disabilities, which is more and more of us, and how to get care integrated, or as we prefer to call it, coordinated, which is a lot of what Helen was talking about. I think it's always useful to start with some evidence about what we know matters to patients and users of services. This stuff ought to be incredibly familiar to you. It's derived from research evidence, from endless surveys, from polling. These are the things that matter to people. If one pattern emerges from those things, it is the things that matter to people as patients are not just medical. In fact, they're not even necessarily primarily medical. They're about quality of life. They're about connections. They're about communication. They're about being seen as a person, not just as a patient. And that's a kind of policy wonks way of describing it. This is what people themselves will say and do say. That things like trust is incredibly important, but not often talked about in healthcare. And that there are things that often get ignored by both health policy people and the health service. Pain, exhaustion, worry, anxiety, fear, things that we don't talk about but are really salient for people's lives. National Voices is one of part of a movement to promote and champion a thing called the House of Care, which derives from the chronic care model that was devised in the States by people like Ed Wagner and others, then got translated into the UK through the Year of Care model that was originally applied to how to help people live more successfully with diabetes, but it's now been extended more broadly. And it's both a metaphor for how to organise a system of care and support for people with long-term conditions especially, but also a kind of checklist of things that need to happen everywhere if it's going to really work. And many of the elements of it are actually things that Helen has already talked about. The importance of creating the conditions in which patients and their families can be informed, engaged, involved in decisions, active participants in their care, a process of care and support planning, conversations which are about what needs to be put in place, which involve the patient, where they're an active participant, healthcare professionals coming together, working together, not in their silos, but in multidisciplinary ways, in a coordinated way, and commissioners providing the foundations for all this to happen in a number of ways, partly by organising the formal resources of healthcare, doctors, nurses, clinics, hospitals, drugs, but actually increasingly the things that are really important to people's quality of life, which cannot be provided by doctors and nurses, but are critically important for people's quality of life, the kind of things that are provided by family carers, by befrienders, by peer supporters, by the voluntary sector, by the 3 million or so people volunteering in health and social care in England. And there's a huge resource out there that we haven't yet found a way of properly mobilising. That, my take-home message for you is go out and think about how to build a house of care if you're not already doing it. Another way of encapsulating the house of care is to think about where we're trying to move away from and where we're trying to move towards. And this is a way of summarising the move away from a traditional medical and managerial model of care that's very much about organising things on behalf of and doing things to patients who have things wrong with them that need correcting, towards a more dynamic, more social model of care that's more inclusive, that recognises the role of the patient, that recognises the patient is only partly a patient but is also a person with a real life and connections, and understanding the importance of mobilising those wider resources. And critically thinking about not just clinical outcomes, but quality of life outcomes. And I sometimes use the example of end-of-life care. A death is a poor clinical outcome, but a good death is something that can only be defined by and experienced by a person who is dying, and how that's organised really matters. And only the patient can really decide how that should be organised. I will conclude by saying that citizen empowerment and personalisation are terms that I think can sometimes lead people to think that this is some kind of sideshow. It's all about being nice to people. It's all a bit faddish. It's not about budgets. It's not about the bottom line. It's not about contracts. Well, actually, organising health and care as if people matter really is fundamental, and it's the only way we're going to have a sustainable healthcare system in the future. And here are some of the key elements for me. First, recognising that people have rights, that health is a human rights issue. It's often couched as a consumer rights issue or a managerial issue. But we'll be hearing from Jay about working in a part of London where there are very deprived communities and where the importance of equalities, the salience for health inequalities and the importance of rights is really quite central. People defining the success of the healthcare. People as partners in their care, people as managers of their healthcare and their healthcare conditions, people as leaders, and I think we'll hear a bit more about leadership for patients and service users in the organisation of services, a really important thing. The healthcare workforce is not just doctors and nurses, physiotherapists and people in white coats, it's all of us. And the trick is to think about how we can mobilise the entire population and community in the interest of delivering better health and better care. No decision about me without me, no decisions about us without us. I just want to leave you with a final little anecdote. I was speaking to Rob Webster, who is the recently appointed new Chief Executive of the NHS Confederation. And he was talking about all the fantastic insight work that he'd done when he was a Chief Executive of PCT in, I think, Leicester, although I'm not entirely sure it was Leicester, but somewhere in the Midlands. But it was a town. And the anecdote is they did some very interesting insight work on why is it that people insisted on going to A&E when they could have used out-of-hours care. And they did some very interesting, sophisticated work. It may not have been that sophisticated, I think it was just talking to people. And what they found out was one of the reasons why people went to A&E out of hours was that it was quite cheap to get there. You could jump in a cab and get there for £3.50. This is how you know it's not London. But if you phoned out of hours and you were, as you were likely to be in this particular community, somebody with a pay-as-you-go mobile phone and the out-of-hours service was a premium number, you very quickly racked up a cost that was far in excess of the cost of it. It was cheaper to go to A&E by taxi. So for me that illustrates a number of interesting things. It illustrates the importance of understanding people's lives in context. It illustrates the importance of talking to people. You can call it engagement, you can call it co-design. There's lots of jargon around it. Going out and talking to people and having a meaningful conversation about what matters to them and what influences how they use services. And I think finally illustrates that the little things are often the big things, which have a huge impact on how you design and deliver healthcare, and they're not about health, they're about the way people live their lives. So no decisions about us without us is really partly a plea for making the effort to go out and having the rich conversations that will help you deliver better care. Thank you.
Thank you very much. I mean, the first thing I will say is that we don't claim we get it all right in Greenwich. This is just our attempt, and I've tried to take you through different sort of levels of way we've involved service users and patients within our system. So I'll take you through some of our governance structures of how we've developed new services together, looking at performance, intervention, specifically some types of intervention that maybe not everybody can experience, and also about our pioneer site. So I'm just going to take you through those issues. The first thing I would say is that what we do try and do in Greenwich is involve service users at all levels. And I've just done a very quick diagram here, and it was a little bit complicated, but the key messages here is we have service users actually on our governing body. So when we're developing all our coordinated services, actually between service users and the third sector, they have as many votes as any of the NHS and the local authority people, and they have exactly the same status. And we've worked with them to make sure that they feel comfortable with that and understand it. And they go right the way through to the hands-on delivering of services in our test and learn site. Where again there are service users actually involved in that, and we've got Healthwatch. We're very lucky. I know I've heard some stories about Healthwatch. We're very, very fortunate in Greenwich. Our Healthwatch is brilliant and have really, really been helpful in getting our stuff moving. And again, what we felt is it's far better for them to do that than us, because it's a much better way of connecting with the population. But I just think it's an important message, and I always say it's about it's not a Blue Peter model. In other words, we don't get one out from under the table and say here's one we prepared earlier to service users. They're very much on board all the way through, and they can actually see how it's been developed. In terms of performance, just looking at how we actually measure success, again, there's the obvious ones, and clearly we've got to look at hospital activity, we've got to look at primary care, social care, and costs and things. But these two are of equal importance, if not greater, and particularly in terms of integrated working. I've got patients and staff experience. Again, what we've done is we've shamelessly stolen all the I statements from National Voices and turned those into measurable outcomes for people, saying how they felt about the service beforehand and how it looks afterwards. And we've also got a control site in Greenwich where we're not currently delivering that model. But we've also seen a real correlation between our staff's experience and, you know, it was that district nurse who was tearing her hair out on a Friday afternoon trying to get some sort of care package, or, you know, the social worker was saying, you know, that damn doctor won't talk to me because he's in surgery and I know he could really. And what we've done with that is we've really talked to them about how they find integrated care. And there's a huge correlation between if you have a really happy staff group, you'll have a really happy, it translates. The patients really experience better services. So we feel it's a really important thing to include in this. And I know we're talking about service user engagement, but we mustn't forget the frontline staff because they're the ones that actually meet up with people. Oops. This is just a way of working, and I just thought it was interesting. I mean, not all adult services carry this. It's called family group conferencing or restorative justice, and it's proved a really, really successful way of working and very empowering for service users. And we use it in all our services, as well as the test and learn site. And it originates from the Maori way of working, and children's services have used it quite a bit. So if anybody knows children's services, they'll be more familiar with this. But just fundamentally, the key issue with this is that family and the service user is actually at the centre of this. So what basically happens is someone gets referred into our system, and we have a third party who are the coordinators of these family conferences. And what they'll do is they'll work out all the people that need to be involved and go and actually individually interview those people and actually check they understand what's going to be asked of them, which is about coming together on neutral ground. It wouldn't be probably either their own home or local authorities. We try and find a neutral setting. And what we actually fundamentally do is, once they've all got together and we've agreed the issue, the professionals all walk out the room and you're just left with the coordinator and any advocates, because it's very useful for people with learning disabilities. And what we do is we actually facilitate them to come up with an answer for themselves. And service users have particularly said they found it really, really useful. It's been really great at maintaining families, where often if we overly intervene in terms of professionals, we can break family units up. But it's proved a really, really successful model, and we continue to use this with very entrenched cases and cases that we can't get any sort of resolution from. And it's proved a really, really good way and a very empowering way for service users to work. And I think it's about us using these different tools. I'm going to talk a little bit about the Pioneer site now at Greenwich. We're one of the 14 sites in England that have been picked as a Pioneer site. And what we're working with, we've been on a journey. We currently already have integrated hospital teams, integrated duty team, emergency duty team, and community rehab teams. And this is the last bit of our jigsaw. And this is really where we're clustering core teams around population bases of about 75,000 in Greenwich. And we'll have about 4 of those sites eventually. But we currently have 1. And what we did was we went out to service users and very much asked them, using the National Voices stuff as a sort of lever in, about what they would really like in terms of coordinated care. And it just echoed exactly what you said. I mean, it was really good to hear that from the local Greenwich people. And then what we did was we put a load of groups of professionals from GPs, social workers, district nurses, community therapists in the same room and said, well, what is it that causes the problem? We know lots of it, you do great, but what is it? And it was those cases that people couldn't come up with a solution. And what really became evident to us was how traditional the tools we used, each profession used, and they just used their own, had a bag of tricks basically, and it didn't matter whether you were a GP, I say a district nurse or a social worker, you tended to use those same tricks over and over again, and how limited their knowledge was across all those services. It was really, really surprising. And so what we did was we tried to develop this core team, and key to this are these care navigators. Now we've gone down the route of having, basically these are like super admin people, they're very, very good, and I always think about my admin support who seem to be, I think I should call her Harry Potter how she organises meetings, so she's, you know, it's a real skill in itself. And basically they're the key contact for the service user, but anybody can refer into the service, and there is a set of criteria. And what we do is we then look at what people need to be involved in that care. So far, out of the people come in, we've had a high usage of mental health. 75% of people have mental health issues. Housing's been a really big issue. Our third sector colleagues have been brilliant about bringing a real richness to it. And they can all be referred into, and we arrange multidisciplinary meetings. And I have to say the GPs were probably the most sceptical people about coming on board, but they've really found it very successful. One of the reasons is there are two documents we have in our system. It doesn't really matter. One's referring in and one's actually completed with the service user. But it follows a very similar pattern. And the first thing we do, apart from basic passport details, we identify a lead professional, and we also identify who the care navigator is or with the contact number. And this is held by the service user or the patient as well. So this is their document. We then very much ask them what they want to get out of it. So it's not about a disease or a condition. We can just say what they actually want. And then what we do is translate that into desired outcomes. So they might be multifaceted and actually list those outcomes. And then we say who's going to do that, by when, and how they're going to do it, and contact details. And so it's very empowering for so they know exactly who's involved, they know who's doing what, and they also have to put by what, by when. And we have got some really unusual ones here. We have one particular patient who actually said, who had very chaotic lifestyles, and I'm sure everybody can relate to this, about someone who really, you know, the community police officer was always around their house. They had half a Ford Fiesta in the front garden, about 27 feral cats in the back garden, and was a constant source of local youths sort of picking on them, and they wouldn't respond to them, they wouldn't conform to the medication, the GP, they had real chronic ulcers. But his outcome was, I'd like you all to sod off. And that's what he wanted to say. And he was quite clear about that. That's what I want you to do. I want you to leave me alone. And so rather than dismissing that, he never engaged with services. So the care navigator, and this is where the skill of people like that who aren't professionals come in, broke it down and said, well, what do you want? What do you think needs to happen then if we're going to do this? If you really want us to sod off. And actually he worked through it. And for the first time ever, he's actually he's actually working with us. And in fact, we just had a phone call from the GP who'd asked us what we've done with him and have we sent him abroad. Because I think for the first time for about 5 years, he's not turning up at the surgery and things like this, sort of, you know, with terrible dressings around his ankles, asking for it to be done. He said, I can't believe it. He said, after all these years, it's not quite the same without him walking through my door now. So it really is proving a really, really successful way of working. The patients or the service users who come through it are really enjoying it. They're finding it very empowering. They know exactly what they want to achieve and they know who's contributing to it. The care navigator is the one person they have to go to. So I've said if they're wobbly on their frame and they're not quite sure whether it's their medication or whether they're not using their frame correctly, they have a chat with the care navigator. There is a link central professional there who will discuss it with them. They then get all the people to lock in and come in when necessary. And it's proving really, really good use of time. And the GPs, who are the most sceptical professional group, have said they've been really surprised that actually what it's done is taken a work away from them. They thought it was going to make a lot of work come to them. And they've been really, really surprised by it. So at the moment, the Test and Learn site's going really, really well. So fingers crossed. And we will roll that out across Greenwich. And that will make our whole matrix of sort of integrated services.
Great, thank you. Great, so we have a couple of minutes now for Q&A. So, fire away. You've heard three kind of very interesting perspectives on this challenge of trying to do something meaningful and tangible to engage patients. What are your thoughts and questions?
So many of the things actually aren't medical. I mean, that's what we're finding. And we have one person with who had chronic migraine that was not being responsive to medical interventions. He'd been through all the different processes and just had this, terrible situation where he was constantly in pain. What we've actually organised is for a volunteer to go in there 7 days a week, to take him out for a walk and to chat to him, and actually deflects him from, because he was sat there on his own with nobody, and we've actually now started to introduce him to other social events. So there's something that's got nothing to do with medical intervention. It's just a different way of looking at that person's needs, and it's those sorts of things that are coming actually to the forefront. And as I was saying earlier, there was a GP who had an older person with a chronic drink problem, and he'd been a GP for about 25 years in Greenwich, had no idea there was a thing called Silver Linings in Greenwich that worked with older people with drink issue. And he said, how can I have been a GP for 25 years here and just not known it? And the first thing we said was, well, we'll refer him to, social worker said, we'll refer him to Silver Lining. And he said, what on earth is this? And it's just all these sorts of, it's just marrying up all these things. And I'm sure all the boroughs are the same. Greenwich is no different, I'm sure. There's huge numbers of resources out there, and it's just about mobilising that. And I say there's a really skilled person called Wendy. She's fabulous. She manages all the care navigators, and she's the person who sort of gets the ingredients right and sort of picks it through and talks to the person referring, and then we'll bring the people around. But I say housing and mental health have proved really, really necessary. 75% of our people have mental health issues.
Can I ask you about the care plans? How are they hosted? Are they on paper?
We have a Word document. I can upload it. It can be uploaded into the GP's Vision document or EMIS. It can be uploaded into Oxley's, and we do a version control. That's how complicated it is. It's why the GPs love it, because it's 2 sides of an A4, and we had long discussions about it, and we and actually said, if this is to be useful, it's got to make sense to the person, and that's why we just did it really simply. And they sign it. I don't know if you noticed that we get over all our information governance issues, because it just says that everybody named on this thing I'm happy to share my information with, and they sign it, and that gets through all your information governance issues.
So if the ambulance
Yep.
arrived at the house, which is, I'm often
Yep.
told, frail elderly, they fall, ambulance is
Yep.
called, and then the ambulance doesn't know what to do with them.
We have a whole integrated service in Greenwich, and there's an admission avoidance protocol for London Ambulance Services. Everybody in Greenwich will get called JET, which is our joint emergency team first. So they wouldn't go to, if the ambulance crew don't feel they need, obviously any, we've got a guaranteed response in Greenwich of 2 hours, and we've been running for 3 years now. We've not missed one. We've been there within 2 hours, and that team has social workers, nurses and therapists in, and we guarantee to be delivering services up till 11 o'clock at night within 2 hours. And that, the GPs love it. They have a rapid bleep, and it's direct to a clinician. So all they do is they say, I've gone in to see Mrs. Jones, she's got a chest infection, she needs some support now, she's a bit low on fluids, and they will guarantee to be in the house delivering, not just be there, they're delivering services within 2 hours. And that's one of the big things of our first stage of integration, and the GPs love it. And actually it's got a good reputation. Most people, if you ask about integration in Greenwich, they'll call it JET. They don't know the rest of it, but it's all there, but they know JET.
One of the things I was struck with the presentations was the continuity issue. Through coordinated care, it's continuity professionals are working with patients, and the care navigators you talked about as well, Jay. And I suppose, how do we make sure that we build that continuity, in either through the information systems we use and or because it's about the relationships with people?
We have a lead professional, so we do identify a lead professional, but the care navigators proved, I think, as the glue really between the two, and we were really debating whether that was right or not going for now, but it's proving very, very successful with the service users. They're finding it quite nice having somebody who's not coming in with a particular professional slant. They're actually finding it quite empowering to sit down with someone and have a conversation with them, that they can actually have a talk. They found it very good.
So you're saving doctors' time. Maybe that gets used very well in other ways. But what I imagine might happen is that over a period of time, if you've got a stable enough population, you're actually reducing the failure demand that takes up expensive medical hospital time.
Don't ask me how, because a really clever person in public health worked out this algorithm. And what we do is they can identify the cost of each intervention. So what we do is we measure at the start of it, saying, well, okay, like the gentleman who went to his GP 5 days a week, we put 5 visits a day a week for that. We put, if he had he went to A&E most weekends as well. We have a history of that. he didn't have actually any contact with social. So we had a price there, and we knew which organisations they came from, and it said pre-intervention, it was that cost going to those people. Post-intervention, it's these people. And what we're hoping that will give us is the ability to be confident about how to move money around the system. And we're very lucky in Greenwich. We have a very positive relationship with our CCG, and we're working on that. I think it's a trickier question when we start moving monies out of acute hospitals, and that's what we're working on. Actually, as a bigger group, is 6 boroughs. But it does give you some very concrete evidence of saying we're taking this activity out of here and it's going here. What we're finding at the moment is predominantly it is more reasonable, because we are taking from expensive to more reasonable. But I don't think you should knock that, because sometimes we've actually realised things have been missed. And it has ended up more expensive, but the experience of the person has been hugely better. So they said, so although our costs have gone up, the quality of care, they said, you know, finally someone's looked at this and actually got hold of it for me and actually understands my whole life rather than little bits of it. So that's why those different ways, the qualitative and quantitative, is important. It's too early days to say how the whole thing will go, but on a bigger note, we've gone progressively down in Greenwich in our care costs over the last 3 years through integration. So I think that's given us the confidence, and the CCG have gone, because their length of stay has gone down, delayed discharges have gone down. You know, all those big indicators have gone down through integrated care. So I think we're a bit braver and willing to take a few risks now.